Hello, it is such a pleasure to be able to be with you, albeit virtually, for your important meeting. And today I'm going to talk about spiritual care, what we need in dying and mourning, new way of accompaniment. So spiritual and existential issues are very prominent at the end of life for both patients and families. I am a palliative care physician. I also do hospice as well as general internal medicine geriatrics. But most of my patients are more seriously ill or have chronic illness. I can tell you that in any visit, I'm working with both the patient and the family or the significant others. Many of these issues can lead to deep suffering, especially if they are unattended. And facing dying is really our ultimate spiritual crisis. And I think globally, because of the pandemic, we've been able to relate more to the issues that our patients are facing, because it is that question of uncertainty and what might happen if we don't live, or if we live, or if our loved one doesn't live. A very, very deep existential and spiritual crises. But healing can occur, healing broadly defined, if the patient is supported in this process and if the distress is attended to. So I'm going to speak about the important role of clinicians and chaplains or spiritual care professionals in this arena. So is healing and transformation possible in the midst of dying? Well, in terms of transformation of spiritual distress, yes, it can happen while living with dying. And if we look at this schematic, when people are experiencing spiritual distress, there's a deep sense of fragmentation. But over time, it's not an instantaneous fix. It's not the same as having an opioid for physical pain, which may take effect within hopefully a few minutes to 15, 20 minutes. It's not like that for spiritual distress. It's really a process of spiritual growth through healing. This was a patient of mine, I call him Gene, and he had pancreatic cancer. He was diagnosed in 2018, lived with that illness, and then died in 2020. He was an incredible person. I so enjoyed working with both him and his wife, who are pictured here. And very deeply spiritual man, and very strong man. And I learned so much from accompanying him. And it is that accompaniment that's so critical. So in December 2019, there is nothing like a diagnosis of terminal cancer, he said, to sharpen the focus on survival, yes, but beyond that, on the wondrous experience of living. And even to the very last day of his life, he had that transcendent joy, that sense that he was in God's hand, that sense that there was a great unknown and he was willing to enter into that. It was beautiful, beautiful to journey with him. So Eric Casal has talked about transcendence as the most powerful way in which one is restored to wholeness. That transcendence may be religious, but it may be spiritual in a completely different way. It can be cosmic energy or some universal belief system that helps a person, or it might be formal religion, but not necessarily. And that's really important, because in terms of our spiritual care of patients, we have to be open to those broader definitions. And I will talk a little bit about how chaplains address that in a broad way as well. So unfortunately, still, we're dealing with care of the physical as separated from care of the spirit in today's health systems. Certainly our work is moving into a realm to be able to change that, but we are still in that arena. Suffering may be hard to witness, and professional development in general does not include that, although we've developed some work at the George Washington Institute for Spirituality and Health called Reflection Rounds that does attend to the spiritual domain and dimension of students, so they can understand that more in themselves as they're called to serve others. Training is needed, and awareness of spiritual distress and how to recognize it, reflection on our own spirituality, practice of appropriate boundaries, and practice of contemplative listening. Yes, this is what chaplains do, spiritual care professionals, but it is also something in Simon Evers' work and others. It is also something that is important for us as clinicians to learn. And it's not easily learned. It is a type of spiritual direction, but also maybe reflective questioning, that it is something very important to learn as we are present to our patients. My colleague, Rick Bauer, Father Rick Bauer, is a chaplain and is now working with us at GWISH, said that his mentor, when he first began missionary work and his work as a social worker and a chaplain and a priest, said, his mentor said, our role is to stand in the face of massive suffering and not run away. So think about that. Think about the patients that you are caring for. There may be massive suffering, and it may be hard for us to stand there and bear that and bear witness. But that is what we are called to do. That is critical to spiritual care for both the chaplains as well as the clinicians. So how do we open the possibility to patient healing in clinical care, address spiritual issues in clinical care, practice compassionate presence, which is deeply spiritual, and then clinicians and chaplains working together? And I love this quote: we don't always need advice. Sometimes all we need is a hand to hold, an ear to listen, and a heart to understand. That is the basics of compassionate presence. We start there. We don't fix, we listen. We don't try to take away. We don't try to give a medication for deep suffering. We really listen to find out what the patient needs to share. And that's key. Very, very important for all of us to do. So there are guidelines in our country, the National Consensus Project for Palliative Care. We contribute to that with our with the guidelines we developed in 2009 with my colleague, Dr. Betty Farrell. And many chaplains were part of that group, including Joan Halifax, chaplains and religious of different backgrounds, as well as secular and humanist and atheist. So spiritual care is an essential component of quality palliative care. Spiritual care services include screening, history, and assessment. So clinicians do the screening and the history. Spiritual care professionals, chaplains do the assessment, and they're performed on admission regularly thereafter. Interventions should use professional standards of practice. So our chaplains, spiritual care professionals, have professional standards of practice as healthcare providers, as well as we, in the basic provision of this. And it should be available to all palliative care patients. Many of you probably know about the WHO resolution for palliative care. And again, it does include the whole person care, physical, psychosocial, and spiritual. It's an ethical duty for us and systems, and it includes spiritual support and counseling as needed. And that was identifying spiritual care professionals. I'm not going to go into great depth in this study. I have limited time to present this material to you, but this was part of a study that I was part of this group. Tracy Balboni led this. It was a study, a literature review, very rigorous exclusion criteria, looking at the literature for anything that's supported in terms of spiritual care within palliative care. And then we ranked recommendations for the implication for evidence for serious illness. So number one, incorporate spiritual care education into care for patients with serious illness, incorporate spiritual care education into training of the interdisciplinary team, includes specialty practitioners of spiritual care. And this was the category of board certified chaplains, spiritual care professionals, as well as others such as spiritual directors and sometimes faith community leaders who practice in their faith communities, not in healthcare settings, that they are at least aware of the suffering that patients with serious spiritual illness have and how to address that. And then evidence for improved outcomes, incorporate patient-centered and evidence-based approaches regarding association of spiritual communities with improved patient and population health outcomes. A lot of data on religious but other communities with regard to outcomes that increased awareness of the healthcare practitioners of the evidence for protective health associations of spiritual community, and recognize spirituality as a social factor associated with health in research, community assessments, and program implication. So now let's look at a model. I mentioned this conference that I did with Dr. Betty Farrell. We brought together people of all different disciplines, faith-based leaders, as well as chaplains, and developed guidelines on how to address spiritual care within palliative care. So the first was to define a definition, and it's a global consensus derived definition. We did this in 2009, we did a definition, and then Monsignor Bob Vitello, myself, and many others met in Geneva with people from the majority of countries and cultures represented, and developed this, updated this to be more globally relevant. So it's dynamic, it's intrinsic, and it's an aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred, and that can be expressed through beliefs, values, traditions, and practices. Intentionally a broad definition. It's not just about religion. And even for religious people, perhaps it's the intrinsic aspect, may be very personal and unique, not just an identification with the community. Very important to maintain that in both the work of spiritual care professionals as well as the rest of us on the clinical setting. And then we developed this interprofessional spiritual care model. It's integral to any patient-centered health system. We're talking now about spiritual health based on honoring dignity, attending to suffering, that spiritual distress and health is treated the same as any other medical issue, that it's interdisciplinary, includes chaplains, and that is the generalist specialist model. The clinicians are the generalists, the board certified chaplains or the spiritual care professionals are the experts, and we need to work in that kind of harmony together, collaboratively, not separately. And that all patients get a screening or history by us and an assessment by the chaplain, and it's integrated into a whole person treatment plan. And what is key to this is provision of compassionate care by all of us. So this is just, again, what I've just talked about as the general specialist model. So I now want to move to strategies for addressing spiritual health. And what's key is advocacy in clinical settings and clinicians, chaplains working together, use of the guidelines. What's essential is framing spiritual health or distress as part of clinical care, that we actually as clinicians diagnose distress, and then we work with a board certified chaplain or spiritual care professional to then work with us on that spiritual distress, because they have the training in that. They may change our diagnosis, but they need to come back to us and tell us how we might continue to attend to the person's distress. And the first step, of course, is that deep listening and compassionate presence. Whole person assessment plan and then training and education is critical. In terms of chaplains in the US, there was a study recently done in 2020 and 2022, looking at the original COMAS 1979 standards in US, and the scope of chaplaincy services were usually tragic situations, end-of-life care being one of them, or accidents or others. Organ donations, very involved in talking to patients about organ donations, role in comfort care, advanced directives, bereavement, and then communication between staff and patients and families in the ICU. There was a large variation that they found in staffing and structure, very large range from volunteer clergy to board certified to having a CPE, clinical pastoral education training program with students, chaplain students. There's some that have 24/7 in-house and some that are only during the day. Activities, as you can see, are very huge. They serve on ethics committees, bereavement, attending. They didn't put here about palliative care, but in palliative care, it's required to have a chaplain. So palliative care teams need to do that. But the conclusions were that even with all these years of professional chaplaincy, that there still wasn't a standardization of scope. So what they did is they looked at 20 top hospitals in the US and looked at the spiritual care departments. There are official spiritual care departments in many, but not all. And looked at requests for these various aspects by request, that's in black, or the gray is by protocol. So requests for staff care, requests for patient care, patient family request, emergency department or traumas, codes, and then deaths, and then end of life. So you can see the variation in whether it's by protocol or by request. That's, again, this is beginning work to try to get this more standardized. Now, professional chaplains here in the US, their training is they have a Master's of Divinity or a Master's of Arts in Theology. And now there's Masters of Arts in Chaplaincy. And I believe Anne Vanderhoek is working in, I know in her country, in Belgium, there is that in maybe other countries in the US. So that's the training. In addition, 4 units of clinical pastoral education. Certification is from the Association of American Chaplain, Professional Chaplain Association, the National Association of Catholic Chaplains, of Jewish Chaplains, and then certification of those chaplain educators is through ACPE, and those are their websites. Now, affiliations, one of your questions to me was, what about affiliations? So many are clergy, many are lay. The majority of Catholic chaplains are women, they're not clergy. They're religious of all denominations, but also secular, atheist, humanist, and there's a large diversity in culture and gender. They tend to be endorsed, not, I forgot the word they use, but they're endorsed in most religious traditions, but also humanist, atheist, and now there's endorsements for Buddhist, Muslim, Hindus, all have endorsers, and there's different criteria for each, but in general, needing to have this basic training. Funding in the US palliative care, there is a requirement. Payment is usually from hospitals and hospices. Hospices also require a chaplain. And their current strategies to develop billing codes for spiritual care professionals. We right now have a V code where we can code under spiritual counseling clinicians, but they're developing specific diagnostic related codes for spiritual care providers, professionals to be able to do that and bill for that under that. So there's a big need for and end-of-life goals of care discussions, and there is a billing code under that. These are chaplaincy organizations in the US, Canada, and Europe. I'm including Ann Vanderhoek's organization, ERG, and this is the Canadian, just so that you can see the variety of organizations. And my friend, Father Rick Bauer, he's an amazing role model for how chaplains can behave. He doesn't go in and just wait to be called. He goes into the hospital. He does both adult and pediatric. He is at Children's Hospital. He goes in and lets staff know, I'm here to help. One of the main things chaplains do is provide staff to us, support to us, and support us in what we're going through. So to staff. So he just comes by and says, I'm here to help. He offers staff support in different ways. Some do just open up a room and say, drop on by, we have tea and cookies. And sometimes clinicians will want to talk to the chaplain and they can do so privately. They also teach us how to model, they model for us compassionate presence, what it means to have that deep presence with a patient. And as I say there at the bottom, so much more. So for clinicians, I tell the clinicians, identify the pastoral care department in your hospital or your setting, meet your chaplains. Think of chaplains as equal members of the team because they are. Consider referrals all the time, not just in palliative care, and work collaboratively. Don't just hit that referral button on the computer or call the chaplain office and leave a message. I need a chaplain in room 202, but work collaboratively. That's the way to get integrated. Also, in this country, we work so hard now, thankfully, on diversity, equity, inclusion. And one of my medical students said, everyone sits together around the table, is respected for who they are. They're treated equally in all aspects of life and care. And this is what is key to spiritual care. My definition of spiritual care is this. It is respectful care. Trace Haythorne mentioned that first to me, my colleague who heads ACPE. It's respectful care. We honor what matters most to our patients. We help them in understanding what gives them meaning and purpose. We help them if they have no meaning. We help them by being present. We help them when they have spiritual distress by referring them to chaplains. We help them by following up on that. We stand in the face of their suffering. We do not run out or hide our nose in our face in the computer. That's what spiritual care is. And it's so incredibly important if we're going to provide respectful care to diverse communities. I was in Switzerland many, many years ago, and I forgot the name of this place, but they have a community building with different rooms of the different religious faiths, as well as secular and humanist. And people come there to learn to respect the diverse populations that are increasingly growing in Switzerland. It's beautiful, beautiful to do that. That is spiritual care. Now, framing spiritual health or distress as part of clinical care is essential to this, especially for those of us that practice as clinicians, but also for chaplains. for many years, people didn't know what chaplains do. Now, understanding what spiritual distress is, they begin to understand the incredible importance of spiritual care professionals. In the National Comprehensive Network developed spiritual distress diagnoses, and these are some of those. We added a few of those from our 2009 meeting. So as you can see, it ranges from existential to maybe religious specific to despair, hopelessness, grief, loss, reconciliation, again, a broad range. And I'm sure this list is going to expand the more we develop research in this area. So the two main pillars to operationalize spiritual care, number one, is creating space for the work of the spiritual care specialist. That's the chaplain, spiritual care provider, however, whatever terminology is used in different countries. And this requires deliberately and thoughtfully creating opportunities for early and ongoing engagement with spiritual specialists. If available, a spiritual specialist should engage with every family and patient facing serious illness early on, at least once, and preferably in follow-up. Number two is those of us that are general, we need to integrate spiritual care by generalists, as well as specialists, into routine and regular assessment information of a treatment plan. Has to be a joint effort between us. Follow-up is by both of us, and it should be dictated in part by the need, but also regular check-ins to see if new needs arise by both of us, by the generalists and the specialists. Using structured assessment and treatment plans so that spiritual health is not overlooked, again, by both of us. And if spiritual distress is identified by the clinician, it has to be addressed urgently, just as urgently as severe physical pain or depression. So this is just a chart. It was published. Happy to send that to you. But this just outlines the three kinds of screening communication tools. So one is screening, it's brief. It's done by any clinical provider who just does regular screenings. Spiritual history taking is a little bit bigger, and it's provided by the physician or the nurse, the clinician, those of us that develop a physician assistant that develop assessment and treatment plans. And then the assessment is initial, ongoing, it's extensive. It's done by the board certified chaplain or spiritual care professional, conceptual framework that guides the interview and development of a treatment plan. It is also an intervention. So I just want to begin to close with a case of my patient, Mike. He, a new patient, started at the beginning of pandemic. I saw him via telehealth, came here, bad divorce, came here to live with his family, but COVID hit, so he was isolated. He also had some symptoms of dementia and possibly Parkinson's. So all of this was present in that first visit. I asked him about goals of care because the question of if you get COVID and are hospitalized, would you want to be intubated? He said, yes, I want to live. I have a little typo there. He wants life and he wants to live. But he then paused and asked me if I thought God would think he was a good man. And, you know, I was touched by that because he just shared his story as a single parent raising 4 children. So my immediate response inside was, of course you are. God would think you're a good man. You're a very good man. But I didn't say that. And this is the presence. I stopped. I listened. I was present and let him talk. And that's a key part in these types of conversations. We developed a tool called FICA, Faith and Belief and Meaning. I have to correct this slide, but it's a spiritual history tool that I developed in 1996, and we've certainly added to that in the subsequent years. It is a history tool. It is something that clinicians can use. It is not to be used by chaplains. They use a bigger tool, but it is, again, spiritual. I dropped the word religious because that was turning to be sort of a hang up for a lot of people. So I just say, do you consider yourself spiritual? If people say no, I ask, what gives your life meaning? But even if they say yes, I ask about meaning, because in our validation studies, this is validated. Meaning may sometimes be not within the religious scope or not even with how they answered spiritual. So it's maybe different. Importance in their life, effect on decision-making, communities, again, not necessarily faith-based communities, can be lots of different ways. Family can be a community, etc. And then assessment and plan in the A. So he was raised Catholic, but spirituality was now more personal, very important, impacts how he deals. He worked with a spiritual director in the past. Community, his family, like-minded friends, in huge isolation, and then the wondering, what he will do in his life with whatever time he has left. a beginning of a bereavement, very brilliant man, recognizing that things were changing for him. Deep, deep, deep suffering with him. So in our review of systems, I picked up these as grief, loss, concern about relationship with God, existential distress, fear of uncertainty about his health and his life. And so then the writing up the whole person assessment and plan, giving a summary, what we would do for him physically, emotionally, socially, and then spiritually. I did connect him with a chaplain who was, and continues to be with him, amazing, working with him now a couple of years. And with the chaplain opened my eyes to, although I always see the whole person, and that particular conversation with the chaplain, I was most concerned that this person was declining and had many hospitalizations, and I was worried about it and was very worried about the physical and his medication at that moment in the conversation. But just in hearing the chaplain talk about what an incredible person Mike was and how he was so brilliant in his work, and he wanted to teach his local Catholic church about environmental issues, and that the chaplain figured out a way he could do that. The chaplain reminded me again that Mike was a whole person, and we continue to see him together and sometimes separately. Just want to close with training and education. We do have a interprofessional spiritual care education program. Our first was in 2018. We now offer it twice a year, once online and once in person. We will start it in person in spring. This is our current course. It's people who, we ask people to come with their spiritual care partner. So it's a chaplain or a spiritual care professional and a clinician coming together. We would be happy for any of you to join. You can connect with us at www.gwish.org to find out information. And you can certainly email me. The organizers of this course have my email, and I'm happy to give you more information. But what's in this course is health as part of whole person care, evidence-based guidelines, addressing distress, assessment, treatment plans, how to be present, ethics in practice, and self-care for healthcare professionals and chaplains, again, working together. So I want to close with a reminder that spiritual care is a human right. My kitty right now is a little distressed, I can tell, but if we can help that, we can identify spiritual distress and treat it. We can be a compassionate presence on the journey with our patients. We can recognize spiritual health as a component of whole health, and we can be there to raise the awareness of the transcendent, to create a space for the sacred and for healing. That's what this care is about. So we have a very exciting initiative advancing interprofessional spiritual care across all of healthcare, across all of clinical settings. We just awarded our first demonstration projects. So our demonstration projects are projects that show how this collaborative model of chaplains, clinicians working together can work. And we believe that more and more of these models, as they get out there, we hope that we can in the future have global partners applying, clinician chaplain partners doing this research together, that will lead to research to show about the importance of spiritual care, and that spiritual care will be totally practiced by everybody and not ignored. That is our dream. Another part of this initiative is doing ISPEC both in the US and globally, and working with global colleagues on making more culturally appropriate, and then partnerships. We want people to sign up. We want to highlight what other people are doing. So please email us. Again, that initiative is on our website, and please email me, and I'm just delighted to talk about partnerships and how we can work together, because I've never been able to work alone. You know, the joy of this work is working with each other and growing this area together. So here's my email, actually. If you want to contact me, gwish.org is our website. And again, thank you so much for allowing me to be part of this meeting with you.